We have a limited repertoire of cytotoxic chemotherapy agents that work for everyone. We know that 5-FU-based regimens, oxaliplatin, irinotecan, added to those work. We have regorafenib in the refractory line. We have TAS-102 or Lonsurf in the refractory setting as well. But when you add biologic agents, when you add cetuximab, anti-EGFR medications, that is a prime example of individualized therapy. Is your tumor left-sided? Is it right-sided? Does it have a KRAS-NRAS mutation, or does it not have a KRAS-NRAS mutation? And you have to know that before you decide on which therapy is the best. So that's kind of the obvious, everyone's familiar with that example. And then you take it to the less common mutations. You have patients with, I talked about before, BRAF mutations, and figuring out what the best combination of BRAF MEK targeted therapy could be for those patients. You have patients who are microsatellite MSI high. You have patients who have deficient MMR proteins. Those patients, we know that immunotherapy works best. We're looking at HER2, which is a small subset, less than maybe 3-4% of patients. And then we're looking at whether HER2 targeted therapy could work for those patients. I think that is key. We're seeing that in a number of other GI cancers. We see that in cholangiocarcinoma, less so in pancreatic cancer, a little bit in gastric and esophageal cancers. That to really make that next step in development, we have these cytotoxics, we have immunotherapy, but really to get the next step, molecular targeted therapies, you really need to sequence these patients. And I think as we're doing that, we'll find more targets, we'll develop more drugs to get there, which will help more patients.